So it's Lyme Awareness Month. So it's May and it's the sun is shining today. So I want to make sure that everybody is checking out all the things that we have are posting on Facebook. So we really want all of you to go out and share information about prevention and things. So we've got things on both of our Facebook pages. We have a public page and a private page. So if you could do that, that would be great. So with no further ado, I would like to introduce our wonderful speaker for this evening. Dr. Linda Williams is a physician and psychiatrist in private practice in the Seattle area. She is board certified by the American Board of Psychiatry and Neurology. In addition, Dr. Williams did a fellowship in child and adolescent psychiatry at Oregon Health Sciences University. Dr. Williams has a long-standing interest in chronic illness and the effects of infection on the nervous system. She has been treating chronic fatigue syndrome, fibromyalgia, and PANDAS since 1996. In 2006, Dr. Williams completed ILADS training in Lyme disease and has been treating tick-borne illness since that time. She is a regular speaker at ILADS, has served on the board of directors of ILADS, and has given numerous talks around the country on neuropsychiatric, hormonal, immunological, and inflammatory syndromes caused by tick-borne disease. And we are so happy and excited to have you here with us tonight. So Dr. Linda Williams.
Well, thank you very much. I will work on getting my screen up here. All right, I think I'm up here. Well, hello, all of you. Thank you for joining me tonight to talk about neurological and psychiatric manifestations of tick-borne illness. I am thrilled and honored to be able to join you tonight. Oops. Tonight, I am going to tell you a little bit about who I am in case you don't know who I am. Talk about some of the basics of tick-borne illness, which many of you are already familiar with, I'm sure. The chronic neuropsychiatric symptoms related to the infection, what's causing that set of symptoms in the brain, and some of the treatment strategies, including both my own strategies for what to do with patients and choosing medications, and things that you can do yourselves. I'm not sure why that's doing that. Okay. I'm a native of the Seattle area, and my original interest in graduate school was ancient neurotransmitters and neuromodulators in invertebrates that were responsible for mood and behavior. I'm board certified in psychiatry and neurology, and I trained in child and adolescent psychiatry. The majority of my practice is adults, but I do see grade school age children through adult. I've been involved in the International Lyme and Associated Disease Society since 2003, served on the board of directors as well as various committees, and I'm currently a member of the ethics committee. My practice specializes in diagnosis and treatment of complex medical problems, including tick-borne disease and its neuropsychiatric complications. I am like a lot of you in that many years ago, I began having a variety of unusual symptoms. I went through multiple different doctors. And because I had recurrent erythema migrans rashes, nearly every doctor that I saw ran an ELISA test, but those tests were always negative for Lyme disease. Over the years, I received diagnoses of both fibromyalgia and chronic fatigue syndrome. Then finally, in 2003, I received a diagnosis of tick-borne disease and was able to receive treatment myself. As a physician, I started treating complex illness in the 90s during residency. They allowed me to have a chronic fatigue syndrome and fibromyalgia clinic. I've been treating tick-borne illness patients since 2004. I have an interest in pandas and PANS that started when I was doing OCD training during residency in Oregon in 1997. And now we know that autoimmunity, creating psychiatric symptoms, can develop from other infections as well, when then we were really only just testing for strep. I do see a lot of patients with autoimmunity as one cause of their neurological and psychiatric symptoms in my practice today. We know that Lyme disease is a debilitating condition that is spread geographically. It continues to be inadequately recognized clinically. Treatment, when it is offered, is often inadequate. There is no laboratory test to rule out tick-borne illness, and very often psychiatrists are the very first physician to whom the patient presents. In psychiatry and in neurology, we see both patients who have already been diagnosed and have a doctor or clinician treating their infections. And we see patients who have not been diagnosed and who are coming to us with maybe more basic psychiatric or neurological complaints that end up ultimately being tick-borne illness. Patients are typically high-functioning individuals who come down with a sudden flu-like illness, or they can present as having a series of vague symptoms that gradually progressed to more serious symptoms prior to their diagnosis. Psychologically, patients may feel they've lost their sense of value in the world and their self-worth. There is a loss of identity. Perhaps they're no longer able to do their job or the schooling that they used to do. Patients can have relationship difficulties, wondering if they're a burden now to their family or friends. Perhaps this is the first time they've ever been dependent on others in their lives. Patients can also have rage and angry outbursts during the course of the illness, and this can affect their relationships. And at the same time, premorbid issues such as childhood trauma, PTSD, attachment issues, and schizophrenia sometimes are still present after treatment. It's important to remember you're not your illness. By the time they receive a diagnosis, tick-borne disease patients can have been traumatized by doctors, hospitals, family, or friends. They can have a history of being hospitalized against their will. Perhaps you have seen some of those people or talked to them. Lyme patients are typically very knowledgeable about Lyme disease out of necessity. So during this talk, I will mention some prescription medications. When I talk about a prescription medication, many of those will be being used off-label. I prescribe by the mechanism of action rather than by the FDA category. The FDA approval is something that a drug company applies for that has to do with where they will market their medication. So a pharmaceutical company may say there's a good market in this particular illness, so they market for that, and that's what the drug ends up being labeled. The mechanism of action has to do with how the medicine works in the body, how the brain utilizes the drug, so how we can use it for healing. And these can be two very different things. For example, an anti-epileptic drug may have anti-inflammatory activity, and it can decrease nerve excitability in the peripheral nervous system. And so we use it for anxiety and for pain reduction. I will also mention some dietary supplements. Some of you may use these. They have varying amounts of literature behind their use. Patients will come in and be on multiple medications. They could be on several herbs and vitamins. These days, there's peptide therapies being used. Amino acids are also sometimes used. So there's typically polypharmacy going on, meaning that the patient is on multiple medications and things. So we have to run complete interaction checks and be very cautious on everything that the patients are taking in. And also we need to remember that not everything is Lyme. Even after the diagnosis is made, it's important to constantly be on alert because things will come up that are not related to the tick-borne illness. I've had a patient who called in with symptoms of a stroke and believed that it was related to their tick-borne illness. Now, this could very well be the case, that stroke symptoms could be related, but it is important to rule these things out, particularly illnesses or conditions that have devastating consequences like a stroke if not treated early. Physicians sometimes will be reluctant and have difficulty when going to the emergency room, or other clinicians and physicians who are not aware with Lyme disease. Even if the condition that they're going to the emergency room for is not related to their tick-borne illness. They are often disbelieved and thought to be lying or faking their symptoms or medication seekers. So your physician that you have now and your other clinicians around you should help you with strategies for dealing with this in advance so that when you get to the emergency room, you're prepared to deal with what they're throwing at you. Unfortunately, there's a stigma related to Lyme disease and other invisible illnesses. So physicians and clinicians who perpetuate this stigma associated with these diseases, shame on them. So these are just some of the neuropsychiatric symptoms that we see. Patients can have full range of affective symptoms, which is all the mood disorders, depression, bipolar symptoms. They can have psychotic and anxiety disorders, as well as cognitive problems. They can have light, sound, touch, sensitivity, chemical sensitivity, focal neurological deficits, and seizures. Tick-borne diseases can cause any symptom in our diagnostic and statistical manual, and patients can have up to or as many as 100 symptoms. Sometimes we don't like the DSM that's used in mental health. There's a lot of criticism about it, and the criticism is certainly valid. But the DSM describes a syndrome, a set of symptoms or a symptom complex that is commonly presenting to us in psychiatry. And it's a worthwhile classification primarily for communication between doctors and therapists, and communication, unfortunately, with our current insurance industry. But it should not be mistaken for addressing the cause or the etiology. Psychiatrists use what's called a biopsychosocial model for diagnosis, or more specifically, this is a diagram of some of the things that go into our working diagnosis. There are environmental factors, the history of the disease, cultural aspects. And cultural aspects mean, for example, if something is acceptable and common within a particular culture, it wouldn't be abnormal to experience it. For example, in a part of Indonesia, there's a culture that believes that drilling out and filling 2 teeth to keep evil forces away, such as greed, stupidity, jealousy. Well, within that culture, if someone was acting in that manner, the belief is not delusional. But if we saw someone, say in downtown Chicago, who they were drilling their teeth out to ward off evil spirits, we might say that was delusional. There are checklists online and that your doctor will likely have you fill out. These are good additions to diagnosis. But what it really is recognizing patterns after seeing thousands of patients. So seeing thousands of tick-borne disease patients helps us to recognize how these infections present themselves and to distinguish them from other illnesses and other conditions that present in psychiatry. So a knowledge of general medicine, as well as psychiatry, as well as neurology, a thorough physical exam is necessary, as well as the mental status of the patient. And then we take into consideration, after all that, the laboratory analysis. So while a checklist that you see online or that you're given can be helpful, the diagnosis is much more than that. Here's some of the other symptoms that we see present. There's no one symptom that we say is pathognomonic or that absolutely means a particular disease, in this case, tick-borne illness, except perhaps Bell's palsy. The trigeminal nerve pain that I see in patients seems to be quite a good indicator of tick-borne illness. At least it tells us to look further in this area. I also find that buzzing or that electrical sensation, sometimes patients get, that will also elevate my index of suspicion for Lyme disease. Brain imaging, while it is not diagnostic, I will sometimes order it to make treatment decisions or to support a case for an insurance company claim. Sometimes we can see lesions on an MRI scan, as well as hypoperfusion on a SPECT scan. And these tests can be run at your local hospital and don't require a special private facility. The term Lyme disease is a catch-all term that originally only referred to Borrelia burgdorferi. And now we know that there are a collection of microbes, co-infections, but the term Lyme disease is still used by patients, social media, and doctors to identify each other and to identify the doctors that can help them. So while it's not the best term, I still use it for that reason. These are some of the co-infections that we find along with Borrelia. Personally, I have never once found Borrelia alone in a patient. I have always found it with at least one co-infection. So these have to be taken into consideration when you're making a diagnosis and then also the treatment plan, because many of these co-infections are not treated with the same antibiotics or antivirals that Borrelia is treated with. Viruses can be another factor. These viruses can either be transmitted by the tick or they can be reactivated latent viruses in the host or the patient. For example, most of us carry at least one of the herpes virus strains in our body, typically in our nervous system, possibly Epstein-Barr, and some of us carry cytomegalovirus. They live within us, and most of the time they're pretty quiet. But when we have stressors, for example, inflammation or other infection, the viral titers can increase and begin to cause additional symptoms. I see a lot of Bartonella in psychiatry. It is an intracellular bacteria that can live in the endothelium or the blood cells that make up the blood vessels, and it can also live inside of the red blood cells. These patients will present with neuropsychiatric symptoms that are most commonly panic, rage, sometimes intense rage, anxiety of all types, and seizures as well. It can be transmitted by the tick and also by fleas. So if you have an indoor-outdoor cat or you've ever been around a cat, that flea gets on the cat and gets and poops on the cat, essentially. Cat scratches itself and then transmits it to you via a cat scratch. So that is why Bartonella has been called cat scratch disease. There are approximately 476,000 people that contract Lyme disease every year. This is about the same number that are diagnosed with multiple sclerosis. Lyme disease is an extremely complex illness that's difficult to treat, except in its very, very early stages. Clinically, it can be classified into 3 stages: the localized acute infection, which we sometimes see as erythema migrans rash, early disseminated disease, such as arthritis, flu-like symptoms, and late stage disseminated disease, which is neurological. Chronic Lyme is a neuropsychiatric illness. So after the blood meal, we can see changes within the blood-brain barrier within 12 hours. Within 2 weeks, Borrelia can be found inside the central nervous system. Both the germ and the inflammatory response to the germ, that's what's creating the neuropsychiatric symptoms. We can't treat one without treating the other. If we were somehow magically able to eliminate all of the germs, we would likely still have symptoms present. And that's because some of these inflammatory changes that we see in a patient are self-perpetuating. Patients can have central nervous system effects as well as peripheral nervous system effects, those nervous system effects that are outside of the brain. Treating the neuropsychiatric illness and symptoms will help to prevent further brain inflammation. Spirochetes are a family of bacteria. Some of them are fairly benign. There are the spirochetes that live in our mouths, and others are serious pathogens that include Borrelia, syphilis, and leptospirosis, as well as others. Borrelia burgdorferi is a complex bacterium with over 300 genes and over 20 plasmids. When bacteria have sex, they are able to communicate information from one bacterium to another. Some of that information that is communicated includes resistance codes for the bacteria to antibiotics, and it includes their ability to adapt to many other different hosts. In addition to being difficult to treat, the bacteria can remain dormant for years. After having a period of dormancy, the illness can surface with a major or even minor stressor. Childbirth, surgery, puberty, a traumatic event, or even just a period of sleeplessness can bring down the body's defenses enough to allow expression of the disease. How well any particular patient does in treatment is, of course, related to that treatment that the patient is given, but also related to the age of the patient. Younger people do better, and also how long the individual has been infected contributes to how well one does in treatment. These days, patients are getting diagnosed earlier than they used to, even 5-10 years ago. And that's a very good thing. Syphilis, also having that corkscrew shape like Borrelia, has an acute dermatological stage, a systemic inflammatory stage, and the later neurological stage. The bacteria itself is not nearly as complex as Borrelia, and syphilis is much more easily treated. These are photos of the dermatological lesions in both syphilis on the left and Borrelia burgdorferi on the right. And you can see the similarities. Only about 30% of people infected with Lyme disease get the diagnostic erythema migrans rash. treatment of Borrelia is difficult because it can change its shape. It has a cell wall form, which is the typical corkscrew that you see. Then it can shed that cell wall and move intracellular. And then when conditions in the body are poor, it will form what's called a round body or a cyst. The bacteria can also secrete mucus and live in this mucus in biofilm communities where they communicate with each other and share DNA. The tartar on our teeth is a biofilm, and it is secreted by the bacteria in our mouths. So this kind of secretion and living in this mucus is very common. Neuropsychiatric or brain-based effects are broad. They can include seizures, mood disorders, psychotic disorders, anxiety, OCD, intrusive thoughts, social anxiety, and autism spectrum disorders. And inflammation is a big factor that I'm going to talk about in the development of these neuropsychiatric symptoms. The host response is variable. There are people who can test positive for the infection but have no symptoms. And there are also patients who test negative and still have Lyme disease. Many of these patients, when I start treatment, will go on and test positive with the antibiotic treatment. We call these seronegative patients initially who have the negative testing, but the clinical signs. They'll have the clinical presentation, and we recognize that as fitting into that pattern that I was talking about of tick-borne infection and multiple symptoms that are consistent with the illness. Possibly, but not necessarily, signs on physical exam. So while it is not just a matter of testing positive, I have found that most people who have Lyme disease would like that positive test prior going down the long road of treatment. They want to see the positive test, preferably. The treatment is expensive. Physicians are still hard to come by that treat the illness. And the treatment itself is not benign. So when we're treating, we want to keep in mind what we're treating, the disease, but also the general health of the host or the patient and the environment or milieu that the bacterium is living in. So what are the contributing factors to the symptoms that present in psychiatry and neurology? There is direct injury to the brain and to the vasculature by the microbes themselves. There's the inflammation that occurs. There's an increase in cytokines as the result of the inflammation. The inflammatory state also creates an imbalance between the neurotransmitters GABA and glutamate and causes an alteration of the monoamine metabolism, which decreases serotonin and increases a neurotoxic compound called quinolinic acid. There's an increased activation of NMDA or N-methyl D-aspartate, and that is a receptor on the downstream nerve cell. These are important alterations in the brain. I'll talk more about them later. There are also alterations in the immune system. We've been hearing a lot of it, all of us have been hearing a whole lot about how inflammation and the cytokine cascade is a contributor to the decline of the health in COVID patients. Just as in COVID-19 patients, tick-borne illness patients' course is highly dependent on the degree of the inflammation. So it's important for us to understand inflammation and what we can do about it. The Borrelia lipoproteins are highly inflammatory and cause the neurochemical imbalances. And the bacteria that adhere to the lining of the blood vessels can cause inflammation. The inflammation contributes to the brain symptoms, and then the symptoms that you're having psychiatrically themselves go on and create more inflammation. So it's a positive feedback loop, and treating the neuropsychiatric disorder will help to prevent further brain inflammation. These are some of the inflammatory changes that we see. An increase in interleukin-6 is known to cause fatigue and malaise, kind of a flu-like syndrome. There is a decrease in brain-derived nerve growth factor, which is important in mood disorders and depression. A decrease in dendritic sprouting, which is what happens in just a healthy brain. The inflammation creates an environment in the brain that results in the imbalance of the neurotransmitters, and the increase in glutamate and decrease in GABA results in excess glutamate. Glutamate is excitatory. It is the gas pedal in the brain that tells the nerves to go. GABA is the inhibitory neurotransmitter. It's the brake. The excess glutamate increases triggering of that downstream NMDA receptor, lowering the threshold for neuronal signal. This results in an increased sensitivity to noxious stimuli. So some of our chemical sensitivity, sound sensitivity, light sensitivity, we have a decreased threshold to neuronal sensory input. Then there's that increase in quinolinic acid, which is neurotoxic. It also causes a decrease in serotonin and a decrease in melatonin. So these changes decrease the neural activation of reward circuitry, so things that make us feel good, a decrease in the sense of satisfaction. At the same time, there's an increase in anxiety and alarm, increased irritability, rage maybe, and discomfort. There's an increase in enzymes contributing to motor and cognitive function, so our sort of cognitive clouding. Increases in interleukin-6 are implicated in depression and schizophrenia. Just as there is recent data, fairly recent, linking heart disease to inflammation, there is good data linking psychiatric symptoms to inflammation. So nearly every journal that I pick up in psychiatry, there's another article on inflammation, depression and inflammation and schizophrenia, bipolar disease and inflammation, anxiety, PTSD, and Alzheimer's disease, all being linked to inflammation. We don't necessarily know entirely. Inflammation comes first and then the disease presentation, or if disease actually causes the inflammation. It's likely a little bit of both. There's a lot of attention that is paid to how difficult the germ is to kill. But many other things, sorry, I'm behind a slide. Many other things go into healing besides killing bugs, including the length of time to diagnosis, of course, and things that are just as important to recovery, including support from the patient's family and friends, their emotional health, stress, the lifestyle of the patient, and the trust between the patient and the physician. Some of these things you can control and others you can't. This is a recovery wheel that I made last year for a talk I gave. And it includes all of the aspects of neuropsychiatric tick-borne disease, including the co-infections, whether there's a history of head injury, mold allergies, the emotional health of the patient, the viral load that the patient is carrying, hormonal state, the time between the infection and the diagnosis and treatment, autoimmunity, and diet. And you might be surprised, or perhaps you're aware of how much you can actually accomplish with dietary changes alone. Some of the things that you do have some control over are your activity level, beliefs and behaviors, your microbiomes, emotional health, some control over that, negative thought processes, detox. And by detox, I don't mean anything fancy. I'm really talking about making sure you're sweating, urinating, and that your bowels are moving. You have some control over your environmental conditions. For example, I once treated a patient who lived from sofa to sofa at various acquaintances' houses, and sleep on the sofa was pretty poor. Many of the houses were in upheaval. I've also seen patients in unhealthy relationships, and I can tell you it's very, very difficult to get well in those circumstances. So treating the psychiatric symptoms with psychotherapeutic interventions can lessen stress, improve functioning, and prevent further decline. And while psychotropic medications can also assist the patient in tolerating antimicrobial treatment. So as you may be aware, antimicrobial treatment sometimes increases symptoms before they get better. So the psychotropic treatment can help to allow patients to tolerate treatment. The medications themselves are often anti-inflammatory. They can be neurotrophic and also neuromodulating. And then there are patients who will say to me, pretty regularly I hear, I don't want to treat the symptoms. I only want to treat the infection. So I do hear this, and I want to respond to that like I do in my office by looking at this circle, remembering that the neuropsychiatric symptoms cause inflammation, and then in return, inflammation causes the neuropsychiatric symptoms. So you have to cut into that circle somewhere. We have a saying in psychiatry and neurology: first, stop the seizure if a patient is having seizures, because the longer you let it go, the more it is likely to create pathways in the brain that allow it to continue and to magnify. Maybe you've had the experience of walking through the woods and making your own path, and you're aware that the more often you walk down that path, the clearer the path gets and the easier it is to go down that path. That pathway is kind of like the pathways in your brain. The more times you have a seizure, the more times you're psychotic, the more often you're depressed, the more easily it is for your brain to go down that pathway, and we call that kindling. So by treating the symptoms, we are breaking that cycle, and in return, treating the disease. Again, many of our psychotropic medications are antimicrobial, are anti-inflammatory, and can increase BDNF, brain-derived nerve growth factor. When we look at the history of a medication, we can see that their use changes over time. We know that disulfiram is now being used as an antimicrobial in Lyme disease. For many years, we used this drug in psychiatry for alcohol abuse. We still use it that way when it's called for. Another example is chlorpromazine, which is currently classified as an antipsychotic. It was originally discovered while searching for an anti-malarial drug because it was used to treat parasitic worms in livestock. Then it was found to be useful during surgery as a major tranquilizer. So an interesting thing was discovered that when schizophrenic patients underwent surgery for whatever reason, they received chlorpromazine as a tranquilizer. After surgery, those psychotic patients were less psychotic. So it turned out that chlorpromazine helped with psychosis. So today, that's what it's used for. So you can see that chlorpromazine, in addition to being sedative and antipsychotic, is also antiparasitic. So none of these medicines, whether prescription drugs or over-the-counter medicinals, are as straightforward as they seem. So our treatment, excuse me, our treatment focus is going to be symptom reduction to be able to better tolerate the antibiotic treatment, treating the inflammation, and alteration of the neurotransmitter metabolism. And changes in neurotransmitter availability within the brain. We can increase or decrease the signaling and the triggering of some of these receptors in the brain using what we call agonists or antagonists, depending on the result we want. An agonist is a molecule that increases or supports the triggering of a particular pathway, and an antagonist, it's kind of like the word sounds, it interferes with or it helps to block a particular pathway. Because the illness in the brain has developed these patterns which cause the disabling symptoms, and through treatment, we want to coax the brain towards a state of health. One of our treatment targets is monoamine metabolism. In an inflamed state, we get a decrease in available serotonin, norepinephrine, and dopamine neurotransmitters. And there is a corresponding increase in quinolinic acid. So this is a little very simplified cartoon of this, where in an inflamed state, you can see on the right, goes down to quinolinic acid, and on the left, in a state of health, we're making more serotonin. The result of that, of course, is a decreased sense of reward, an increase in arousal, anxiety. And then we have a more detailed picture of the same interaction, where you can see that melatonin is actually produced from serotonin. So if you're not making enough serotonin, you're not making enough melatonin. Then the increase alone in quinolinic acid is not great for the brain at all. It's very bad. It directly correlates with the severity of the central nervous system symptoms. So if we were to go in and sample quinolinic acid in patients who are severely sick clinically, in terms of nervous system disease, we would see that there's a higher amount of quinolinic acid. It is toxic to the nerve cells, and the decrease in serotonin also causes an increase in pain sensitivity. And of course, the increased susceptibility to mood disorders. When there's a decrease in dopamine, dopamine is that neurotransmitter that makes us experience pleasure. And it also assists in cognitive ability. Dopamine is what we target when we treat ADHD. So we're increasing dopamine in the prefrontal cortex. So if there's a decrease of dopamine, we're going to struggle with that cognitively. Then NMDA, which is the downstream receptor, is excitatory and very, very important for learning and for memory. So we wouldn't want to stop that completely, but its overactivation is what's a problem. People have a startle response, anxiety, and seizures. So that's what's happening in the brain on a molecular level. And you can see it on a clinical level, of course, as the symptomatology of rage, irritability, hyperalert states, anxiety, increased pain, and seizures. In the presence of inflammation, there's that increase in glutamate, leading to excess glutamate and a decrease in GABA. I do have a patient that will occasionally say to me, well, I'm on a lower glutamate diet, or I'm decreasing my glutamate intake. That's something that isn't going to be helpful in terms of your overall brain health. Because if you look at this pathway, in order to make GABA, which we want, it's the good relaxing neurotransmitter, the pathway to make GABA is one direction. It is glutamine to glutamate to GABA, as you can see in this picture. So the only way that you can really affect this is by going after the inflammation. Excess glutamate is neurotoxic and increases triggering of that downstream NMDA receptor. The quinolinic acid causes oxidative stress and wreaks more havoc in the cell. There's cytoskeletal disruption, cell death, and then it increases its own toxicity. So more of it creates a more toxic molecule. It also increases the toxicity of other brain chemicals, and it can produce progressive mitochondrial dysfunction. With the glutamate excess, we have sleep disorders, sound, light, chemical sensitivity, and seizures. So systemic inflammation has a very profound influence on the brain. So here are some things that decrease inflammation: the serotonin reuptake inhibitors, the SSRIs, Prozac, Paxil, that type of medicine. They decrease inflammation. Our second generation antipsychotics that include quetiapine, ziprasidone. Also the antibiotic ceftriaxone is highly anti-inflammatory. And then this is a list of some over-the-counter supplements that have some literature support as anti-inflammatories. Maybe some of you take curcumin, or you know about turmeric. Those are all good things. And these are glutamate modulators, some of them. Some of the prescription medications that modulate glutamate that I like in my practice, and then some of the over-the-counter supplements that you can take. Then this is just a short list of NMDA antagonists. So that's what we want to do in this illness in particular, is to antagonize NMDA. So in bringing up over-the-counter supplements or nutraceuticals, does your countertop look like the picture on the right? Or does your drawer look like the picture on the left? So I know that it might, because the photo on the left is a picture of my drawer that I took the morning that I made this slide. So this is easily over $1,000 worth of supplements. And so why am I bringing this up? It's because I don't want you to come away from this talk and spend another $1,000 on things to lower glutamate excess. If you're spending over $1,000 every time that you go to your appointment on supplements, and you find yourself searching the internet for droppers of magic potions, I want to tell you that there just is no easy fix. Selling these products is a huge business that makes billions of dollars. And one thing chronic illness does for certain is it causes a huge drain on family finances. So I just want folks to be smart about it. Have serious discussions with your health care team about your treatment, about what supplements and tinctures might be worthwhile and what other ones might not. Your doctors and your clinicians should be helping you to be good stewards of your resources, because resources are typically not endless. In addition, not all natural things are good, and not all prescription medication is bad. This is a slide I kind of like. This is a list of ingredients in an all-natural cherry that might come from Whole Foods, or that you might even pick off your tree if you have a cherry tree. On this slide, on the left is vitamin C, a natural vitamin C extracted from rose hips. And on the right is vitamin C made in a chemistry lab. So drugs, nutraceuticals, whether or not something is a prescription, natural versus human made, it's just not so straightforward. So please be smart, because when we're sick, we're very vulnerable. So these are kind of the main symptoms presenting to psychiatry that I see. Which symptom and how do we prioritize? Which one do we treat first? We want to treat the symptoms first that most interfere with recovery. Sleep is absolutely essential to recovery. I like to say in my practice, patients need to sleep at all costs. And what I mean by that is that I want to use a combination of medicines, maybe supplements, medicines that will ensure sleep, even if the patient has to call my office on a daily basis every morning with updates to get changes in dose or treatment plan until they're sleeping. Reports of sleep disorders in Lyme disease patients range from between 80% to 100% of all patients. They can have difficulty initiating sleep, frequent nighttime awakenings, daytime somnolence, and restless leg. Many patients report a completely shifted diurnal pattern where they're up all night and sleeping during the day. REM sleep is important for memory and learning and regulation of the blood-brain barrier. Non-REM is important for growth hormone and prolactin secretion and tissue repair. Sleep loss increases emotional dysregulation, cognitive dysfunction. Sleep loss impairs immune dysfunction, impairs immune function, and sleep deficiency is pro-inflammatory. In addition, sleep loss is a risk factor for neurodegenerative disease. Sleep disturbance and tick-borne disease are likely related to an increased state of overactivation caused by the inflammatory state. There are many options for improving sleep quality and improving duration of sleep. You should discuss these medication options with your physician or other clinicians. There is not a one-size-fits-all medicine. Some of these medicines improve slow wave sleep. Some are neuroprotective and decrease glutamate excitotoxicity. Most of these medications can be used in combination because they have different mechanisms of action and many of them do not interact. The dose varies wildly depending on the individual. Trazodone, for example, I have dosed it anywhere between 12.5 milligrams and 500 milligrams. So like most treatment in tick-borne illness, one dose or medication does not work for all patients. Some patients require very large doses and others require very small doses, perhaps even fractions of a pill. There are non-prescription over-the-counter sleep aids that you can try. Some people do very well with these. Some people are helped with a 10,000 lux light, can be purchased at Costco or online. It's used in the morning for 30 minutes. One of the cannabinoids is an NMDA receptor antagonist. Lavender, which has literature showing it decreases arousal and has some benefit in seizures. Glycine can improve sleep quality and decrease glutamate in some patients. Melatonin is cytoprotective and anti-inflammatory and attenuates the effect of quinolinic acid. So melatonin has some benefit, whether or not it is useful for a particular person for sleep. And a sleep study in individuals can also be helpful. Probably the next most common complaint I hear is brain fog. I have described it as thinking through mud. You can see on this graph, the one on the right, that reports of brain fog have risen over the years. This symptom is reported in autoimmune diseases and illnesses that have elevated cytokines. Patients report a decreased ability for critical thinking, impaired spatial memory, impaired attention, concentration, and comprehension. There are prescription medicines that can be used for cognitive impairments, including memantine, which is an antagonist at NMDA. It reduces quinolinic acid, and it can be used also clinically for augmentation in depression treatment. There are a few over-the-counter medicines that have research behind them. Huperzine is an NMDA antagonist. Acetyl L-carnitine is an antioxidant. It modulates the activity of nerve growth factor. Green tea, you've probably heard of that, improving cognition. And luteolin reduces inflammation and is neuroprotective. Luteolin can be found in celery, broccoli, carrots, peppers, and chrysanthemum flowers. Believe you can take it as a supplement, but when you can get these things by these nutrients by food, that is the best way. Some patients get benefit from ginkgo biloba. It might have protective properties against neuronal and vascular damage. Bacopa is also an antioxidant with neural protection, and it has acetylcholinesterase inhibition. So interestingly enough, acetylcholinesterase inhibition is the mechanism of action of many of the Alzheimer's drugs. One of the metabolites of disulfiram, which I talked about a little earlier, antagonizes glutamate and is neuroprotective in animal models. I should also mention that brain training, and there are several methods available on the market, is useful. Some are available for apps for your phone, or they can be done on your computer. Fatigue is profound in tick-borne illness. It is on the same level in severity as the fatigue in patients with congestive heart failure. Treatment for fatigue needs to start with correcting sleep and correcting hormones. Modafinil is a prescription medicine that may enhance cognition and physical well-being and help some with fatigue. It has antioxidants and neuroprotective effects. There is literature also on the use of coenzyme Q10 in chronic fatigue syndrome. I have used it successfully in patients along with subcutaneous doses of B12. Oxaloacetate, which is an intermediary in the citric acid cycle, that is available in animal foods, blueberries, rhubarb, and alfalfa. Some patients also benefit from oxygen therapy, both hyperbaric oxygen, and also just oxygen concentrator that you can use in your home. I will have patients purchase an oxygen concentrator and use it in increasing liters per minute. Looks like I've got to back up a couple slides here. Oops, wrong way. Sorry about that. Okay. Fatigue. There are a number of things that can be used for pain, also major symptom in tick-borne illness and other chronic inflammatory brain diseases. If your doctor is one that uses opioids, they continue to be a useful tool, often allowing patients to have a life that they wouldn't otherwise have. Maybe it allows a mother to get her children ready for school, or a young person to get to college classes every day when otherwise they wouldn't be able to without treatment for their pain. While there's definitely opioid abuse in the world, the war on opioids that's going on right now hurts chronic pain patients. So I would like to see in all the news reports that they do on opioid abuse, I'd like them to include what the chronic pain population is going through, because that is the other side of the story that's really not getting a lot of press. There are alternatives, including drugs in the anti-seizure class that can stabilize hyperactive nerve cell membranes. They can help with pain. There are also creams that I have compounded for my patients that can be helpful. In addition, some patients get help from CBD. It interacts with the serotonin receptor, and that may possess analgesic or anxiolytic properties. PEA is anti-inflammatory at 500 to 700 milligrams 3 to 4 times a day, and it is available over the counter. I also like dextromethorphan, which is available compounded, and that's given several times a day as well. The depression in these illnesses is disabling. The SSRIs and SNRIs can decrease inflammation, help with the neurotoxic compounds, and help with the depression as well as helping with pain and anxiety. Unfortunately, there are many patients who cannot take these. There are alternatives which include lamotrigine, atomoxetine, which actually is an antidepressant drug, but is primarily used right now for ADD in children. And then there are many others. Non-prescriptions alternatives include the omega-3 fatty acids, some herbs, and some probiotics. Transcranial magnetic stimulation has helped some patients, and there are new medications on the horizon as well for depression. Ketamine, I want to spend a moment on, has been useful for pain and for depression. Originally, ketamine was an animal tranquilizer. It started being used for pain many years ago intravenously, and more recently it has found a place as an antidepressant. Chemically, it is an NMDA glutamate receptor antagonist, so it kind of fits in with what we talked about before. It can be used as a nasal spray on an as-needed basis. I use it in my office as an intramuscular injection as well, and it can be used as an IV infusion. The first papers in psychiatry on ketamine showed its benefit in impulse control disorder and anger management, where people carried it and used it on an as-needed basis. So I prescribe it for pain, depression, anxiety. I think it can be very useful. It does have side effects which limit its usefulness, including dissociative symptoms and sedation. So it doesn't have a lot of use at work. It also has long-term, more serious effects for when it is used, especially illegally and on the street. When it's overused, it can have kidney and bladder side effects. Autoimmunity is a factor that contributes to the symptom complex in Lyme disease, with persistent infection, the surface antigens, which are proteins or other bits of the bacteria or virus. Pieces of those are seen by our immune systems, and through a process called molecular mimicry, can evoke anti-neural antibodies, cause our body to actually attack and cause an autoimmune response against our own nervous system machinery. This is what is the case in pediatric autoimmune neuropsychiatric disorder. The Mayo Clinic and the Cunningham panel are very good tests to run for this. The Cunningham panel is a private test. It's a little bit pricey. The Mayo Clinic panel, people sometimes are able to get insurance for that. Anti-nerve antibodies are found in 30% of patients with neuroborreliosis, so it's found quite a bit. The treatment for autoimmune associated symptoms includes anti-inflammatories, ongoing antimicrobial treatment, and in some cases, the immunoglobulins, which are given subcutaneously or IV. There are many other psychiatric presentations of tick-borne illness that I'm not going to get into in detail, but the anxiety disorders, which include, of course, PTSD, OCD, panic disorder, they present frequently along with the co-infections. And we also didn't talk about the psychotic disorders. I see some very serious cases of intrusive thoughts. These are neuropsychiatric manifestations. So like I had said earlier, nearly any symptom in our DSM can be a symptom of tick-borne illness. So what we want to do then with tick-borne illness is to treat the symptoms first that interfere the most with functioning. Treat sleep dysfunction, that is at the top of my list. Fatigue, disabling fatigue, treat depression, treat the brain dysfunction so that people are able to continue to work and have a life, treat pain, reduce harmful inflammation and excess glutamate, and then be the keeper of hope. So I will stop now with this and ask if anybody has any questions. I'm happy to stick around and answer those.
So, probably can't see me.
You can take glutamine. The issue with glutamine is that pathway where you're giving your brain a precursor, a tool to be able to make GABA, which is I think what you want when you're taking glutamine. You're giving it glutamine, but on the way to making GABA, it's going to make more glutamate. So it really depends on the condition in the brain as to what the brain is going to do with it. So if your brain is inflamed and unhealthy and you feed it more precursor, it's probably going to make more glutamate than you would prefer. So you need to simultaneously work on that reduction of inflammation and work on the modulation of glutamate, which I think I had a slide that showed a number of things that I do for modulating glutamate, which is to help the body get to that more healthy state.
Are you accepting new patients?
You know, I do have quite a wait. I can't say for sure right now. I believe we're out maybe 2 or 3 months, but we have a waiting list. So if you wanted to call or email, which is on my website, you know, you can be put on the waiting list, and then sometimes we have an opening sooner. So that's pretty much what I tell people to do is, you know, get yourself on the waiting list, and then that's what we choose, what we pick off of when we have a spot.
Do you ever recommend red light therapy for neurological and peripheral nerve problems?
Now, I'm not sure. Are you talking about laser, like cold laser treatment, that kind of thing?
I don't know.
I guess I'm not familiar with it. I have to write that down and look it up. I'm not sure.
So Justine, if you want to give a clearer thing, if you know more, put that in the chat and we'll bring that farther. Do you have an opinion on how COVID vaccine affects Lyme patients?
You know, I do. My general opinion on it, and personal opinion, I know that there is a lot of variance with different healthcare, people in the healthcare industry. I think that getting COVID and having that inflammatory cascade with COVID is a more serious thing that will hurt people more, Lyme patients more, than the vaccine. So that is my personal opinion. I did have the vaccine, and I can tell you that I had flu-like symptoms for about a week, but I did get over it, and I feel fine. I have talked to people who had extended COVID symptoms, had the vaccine, and that helped turn around the symptoms that they were having as a result of having COVID. There are, of course, some treatments that are being used by some doctors and that I would myself be a proponent of and would use, that are treatments that can be used earlier than hospital care. And it's important for physicians to be familiar with those. But for me, I am recommending it to most of my patients because the illness is so much worse.
Thank you.
Mm-hmm.
Are you familiar with the use of NAD to provide energy to mitochondria?
NAD's been around. I saw it in use in the late 90s as a sublingual for chronic fatigue syndrome. Now there is a subcutaneous peptide that is available through a compounding pharmacy. So you can get it as a sublingual, online or at a health food store for energy. It may or may not help. I have heard pros and cons about the peptide that's being used. I think it's individual.
All right, we're going to go back to that red light question. We did get some more information. This says the infrared red light therapy is a home therapy as described in a book by Ari Whitten. I also do an in-clinic laser therapy 4 times a year for peripheral neuropathy that has been very helpful.
Does the red light therapy help you? There's certainly infrared treatment, infrared saunas. I'm a fan of infrared saunas. I don't really know about the red light therapy, but if it's helping and it's not hurting your pocketbook too much and there's a good trade-off, then it's probably a worthwhile thing.
She said it's hard to say if it's helping.
Okay. Yeah, things like that, I usually say, give it a couple months if you can afford it. And if it's not helping at the end of 2 months, get rid of it. Don't keep paying for it and then add something else onto it.
Perfect. Do you have experience with IgM and IgG subclass labs work? My daughter has very high abnormal IgM and IgG subclass 1, 2, and 4. She has Lyme with multiple co-infections, has been treated for years, and I am confused at why these are high.
Yeah, that's a really good question. Usually when I run that laboratory test, I'm looking for low numbers because I'm looking for ways to possibly get immunoglobulin therapy approved by insurance. And sometimes when we have low numbers, it gives us a reason to use immunoglobulin therapy, which of course not approved for in Lyme, right? So you have to kind of build a case. What are the reasons that you could have both IgM and IgG, both the acute IgM elevation and the long-term IgM elevation? I have to think about that, maybe do a little bit of research on it. I think I have seen maybe some numbers. What I would probably do, and maybe you've done this, I would make sure I followed up and get another titer. I would, if it was my patient, I would say, well, let's get another round in 30 days. Maybe you've done that.
And this is just a clarification for people. Thanks to Mary for NAD is, I'm going to say this wrong, nicotinamide adenine dinucleotide.
Mm-hmm. Thank you.
Yes, so
Yeah,
I'm sure I said that wrong, but for
wasn't
those
too
of you
bad.
looking in chat, you can see it written out. Next question is, I am interested in the idea of anti-inflammatory and antimicrobial properties of neuropsychiatric medicines, including such as lithium. I understand that more and more information about inflammation in psychiatric disorders is being put forward. Is there any increasing information concerning infection underlying neuropsychiatric disease, even such as bipolar?
So infection in I mean, certainly inflammation in bipolar. Infection in bipolar, I'm not sure specifically. I'd have to recheck the literature on that. You do find in psychiatric units in general, not in my area, but our psychiatric hospital system in this country is terrible. But where it's possible to test hundreds of psychiatric patients on a psychiatric unit, you do find a higher than normal number of patients with infections, with lingering infectious disease. It's harder to test them on an outpatient basis. I'm not sure that answered your question. I know you asked about lithium. Um, there is a lot of great data on prevention of dementia and Alzheimer's by low dose lithium. Lithium in a more sort of what we consider a therapeutic dose range in psychiatry. So it depends on if we're using it for the long-term neurocognitive effect of it, which we can use a lower dose of lithium, or if we're using it as depression augmentation, then we need a little bit higher dose. And as it's used in bipolar disease, it's a much higher dose. So typically, I mean, I primarily an outpatient practice. Some of the very, very serious bipolar patients, they're on a very, I would say 1,200 milligrams of lithium a day. And those would be the patients that where we're controlling mania, which is the type of psychiatric illness where someone might be repeatedly hospitalized for. That kind of treatment using lithium requires blood draws and has a more side effects than kind of as I'm using it as an outpatient. I'm using it more for its cognitive benefits as well as its antidepressant benefits. Did that answer the question about lithium? I'm not sure.
I'm just gonna go back quickly, just there was some clarification on the IgG, IgM question.
Oh, right.
And what they said was these are her second ones in 6 months and they are higher. And she also gets IVIG under the CIDP docs and has been getting it for 2.5 years.
So I would think now the physician that you're seeing probably, I'm sure, knows more than I do. But if someone is getting IVIG or subcutaneous IG, that is going to elevate the numbers. So that in itself is going to elevate those numbers because that is what you're getting in that infusion.
Great. Do many supplements such as glutamate not survive the GI tract and so ultimately are not available at the biological process where needed?
Yeah, it's possible. I mean, yeah, definitely possible. So you've got several things going on. Is it going to survive the acidic environment in the stomach? Is it going to survive and be taken up in the intestines? And then there's what is the brain going to do with it? Is the brain going to do what you want with it or not? Kind of unfortunately, there's been these urine tests out there for a while that you can get your urine metabolites tested for serotonin, and then you buy supplements based on the metabolites in your urine. But I can tell you that that is not related to what's in your brain. What's in your brain and what you're urinating out are two completely different things. Just taking serotonin, for example, more serotonin is made in your GI tract than in your brain. So if you take urinary metabolites of serotonin, it doesn't reflect what's going on within the blood-brain barrier. And then inside, and then you have the blood-brain barrier, but then you have the very, very tiny space that's the synapse where you have upstream neuron and downstream neuron. And it's really the serotonin that's in that tiny space, a microscopic space in your brain. That's what we're talking about when we talk about serotonin availability. So, it really is hard to get from these kind of over-the-counter box kits to actually talking about what someone's brain is doing.
Thank you.
Mm-hmm.
All right. Was just told I have autonomic dysfunction in regards to cardiac arrhythmias. Any suggestions?
Oh, gee. Yeah. So probably, you need a cardiologist. And I'm fortunate that we have someone here who is Lyme aware. I mean, I hate to throw Lyme literate around. You have, doctors that are open to it and who are welcoming to tick-borne disease in Lyme patients. And in certain specialties where they're not treating Lyme, but they are okay with seeing Lyme patients. And we do have a cardiologist here, and maybe you have a cardiologist back there. I would certainly say that you need a cardiologist on board because, Borrelia, tick-borne disease can infect the heart very quickly. So you want to make sure that you have a cardiologist on board. And then if you have autonomic effects, you want to be getting a tilt table test or maybe a neurologist. I do some of the prescribing for things like some of the beta blockers to help with dysautonomia. So at some point, you may or may not want to involve a neurologist, depending on who's available in your town.
Wonderful. Earlier in your talk, you were saying that in Bartonella, there's 19 different species. Do those have different treatment protocols? The different strains, do they need different different treatments?
I think I was really just talking about Bartonella in general, that I tend to see a lot of the anxiety disorders that seem to have higher numbers of Bartonella as a co-infection in psychiatry. But I don't really separate it by the type of Bartonella.
And do you have a specific protocol you use for your Bartonella patients?
Yeah, I mean, it depends on the Bartonella patient, but of course, there are the prescriptions that like rifampin, and psychiatry, I like rifabutin because rifabutin does not interfere with psychiatric medications where rifampin does. So sometimes I'll have a patient coming to me from another physician who's prescribing the rifampin, and they have psychiatric instability even though they're on some medications. And first thing I want to do is get them from rifampin over to rifabutin. It's a different formulation that affects patients with psychiatric disease. And both of those, the rifabutin and rifampin, can cause quite an exacerbation of that set of symptoms. I know that there is methylene blue being used. There are some protocols that include methylene blue, some antifungal, and the disulfiram. I believe that's one protocol. So there are several different protocols. There are, of course, the medications that we've been using for some time. And when I was first treating it, I did the quinolones, which doctors got nervous about because of the tendon rupture. Sounds like you're probably familiar with that. But they were very helpful. They worked very well. So, it's a shame, but the tendon rupture is very frightening. There are some physicians that are using the sulfa drugs, Bactrim. I kind of don't like to use Bactrim for Bartonella. I'm not sure it works very well, but I don't like people to become allergic to it. It's very, very easy to become allergic to Bactrim. And you're losing a really good drug for urinary tract infections and for many things in the future. So I try to avoid that. And I think there are better protocols available for Bartonella than Bactrim. And there is an herbal sort of protocols or herbal protocols for Bartonella too. I'm generally not someone that goes that way to start with, but they're out there.
Thank you.
Mm-hmm.
Can MDMR or psychedelics with professional supervision be helpful for resetting the limbic system or other psychotic disorders?
Yeah, that is really kind of an open question right now, isn't it? It's something that's being investigated. I am cautious about that. I'm a little bit cautious even about marijuana. There are some patients that do very, very well under some conditions. But being in psychiatry, I've seen a lot of people with new onset psychosis who, young people, they maybe have a genetic predisposition to schizophrenia. Then they come in and turns out they've been doing a lot of marijuana or some other drug. And that is the sort of straw that broke the camel's back. And I'm a little bit uncomfortable with those psychedelics for some of the same reasons. Is that what are the genetic predispositions of this patient? Do we know whether or not they're predisposed to a psychotic illness? Because our psychotic set of illnesses are multi genetically predisposed. I mean, people have more. It's not a simple one-to-one. One gene that is dominant creates schizophrenia. There's good reason to believe that there are multiple genes involved in that, and some of the other psychiatric illnesses. And so I'm cautious about those kinds of things. Yeah.
Wonderful. All right. I guess this is a clarification for someone. Did you say that rifampin and rifabutin can exacerbate psych symptoms? Asking about OCD anxiety, can you take those as the sole antibiotic?
Well, you can. I think if you have disabling psychiatric symptoms, you want someone managing those. So in other words, particularly with rifampin, less so with rifabutin, you probably are going to have to increase the medications used to treat I think was it OCD or anxiety that you had mentioned. But typically when I'm managing someone who is on one of those drugs, I'm having to increase the psychiatric meds a little bit in order to compensate for the increase in symptoms and to make someone comfortable. Also, rifampin in particular interacts at the liver with many, many drugs and lowers the serum concentration. So if I have a certain concentration of drug in a patient's system going into treatment with rifampin, the rifampin is going to lower the general serum level in the bloodstream. Maybe you're used to getting liver function tests all the time, more so when you're on rifampin, because it really works the liver. Now, I mean, that's what the liver does. That's its job. It detoxes medicines and toxins all day long. So it can do it. And it enjoys its job. But when you overload it, you bog down that road in the liver. And so, sometimes you, particularly like rifampin, you do things like the liver has to make more enzymes to keep up. And by making more enzymes, it degrades more drugs. So it just has to be monitored very closely.
Perfect. I'm going to give everybody 15 seconds if you have one more question here to get it up on the chat. If there's anything else. Oh, here comes one. My sleep is 100% affected by temperature of bedroom. It must be 63 degrees. Is that inflammation of the hypothalamus?
People with Lyme disease are typically, not all, very sensitive to temperature. And I would say heat, people are more sensitive to heat from what I've seen. Although in general, I would say the window of comfort is small, you know, for these kind of disorders. You know, we tolerate less of the colder temperatures and we tolerate less of the sort of hotter temperatures. But heat seems to affect people more than cold. So, you know, run that thermostat down.
What is your website?
Oh, it's just, does it have my middle initial in it? I can't remember. It says Linda Williams, MD. I don't think there's an L in it. .com. You know, I am not internet savvy. And so it's kind of just a basic, you know, you can email me through there. It's got my office phone number on it. Does it have my middle initial in it? At my IT.
If you Google Dr. Linda Williams, Seattle, Washington, you'll come up with her website.
My husband is doing IT. In case I need it.
Oh, one last question here. Sorry if I missed this.
Okay, no, it's just lindawilliamsmd.com. That's all.
lindawilliamsmd.com. Perfect. Sorry if I missed this. Can rifampin be taken alone or must it be paired with another antibiotic?
Yeah, you know, general wisdom is that you should be taking a little bit of something else. A little bit of minocycline, a little bit of, you know, one of the macrolides like Zithromax, you know, azithromycin, erythromycin. That's kind of the general wisdom.
Well, perfect. I am going to say what one of the chat people said here today. Thank you, doctor. You are excellent.
Oh, thank you for having me.
If everybody could just turn on their sound, leave your cameras off, but if you could turn on your sound. And I would love to give a big round of applause to Dr. Linda Williams for a very wonderful presentation.
Thank you very much. It's an honor to be here.
Thank you.
So yeah, you can take a chair bow.
Thank you.
Yay. Yay. I'm gonna turn off this recording here, but